Interrupt. We are running late by 1 hour. I welcome you all to the second last session of the day, that is Master's Stroke. I now invite Dr. Amitabh sir to come on the dais. Please take the chair. And Dr. Bhavesh Chandra sir, Dr. Santosh, please. Nice. Dr. Vivek, if he is here. Dr. Ajay Sinha sir, not there. Dr. Neha Kumari. Okay. So we'll start the session. May I now invite Dr. Ravi Kumar to talk about a study he did on RCT on change of Brooks membrane opening compared between bimatoprost and placebo. Please come.
Good afternoon, respected chairperson, panelists, and my society members. I am Dr. Ravi Kumar. Today I am going to present the study of reversal of Brooks membrane opening parameters after IOP reduction by 25% with topical anti-glaucoma medication versus placebo in glaucoma suspect patient. It's a randomized control trial. My co-author is Dr. Bhavesh Chandra sir and Amit Raj sir. I have no financial interest to disclose. So, biomechanically, IOP-induced stress and strain are thought to play a major role in the remodeling of the optic nerve hair tissues. Recently, Brooks membrane opening derived neuroretinal rim parameters were shown to have better diagnostic performance and better correlation to the visual field compared with the traditional disc margin-based rim measures, that is RNFL. Better understanding of the mechanical response of the nerve fiber layer to IOP elevation may be useful for improved glaucoma medication. So this study will help in estimating early BMO changes correlating with disc changes and early diagnosis and management of the glaucoma at stage where no RNFL thinning has even set in. So this is the picture of OCT showing the Brooks membrane opening, and this second photo is showing the minimum rim width from the internal limiting membrane to the BMO. So the primary objective of this study was to study the reversal of BMO MRW parameter after IOP reduction with topical AGM in this suspect, and secondary objective was to compare the reversal of the BMO parameter between the intervention group and the placebo group. This was conducted at Department of Ophthalmology, AIIMS Patna. It's a RCT, prospective, single-centered, and the study period was 1 year. Inclusion criteria were any disc suspect patient of age 35 to 60 years with positive family history, open angles, IOP should be less than 21 mm of Hg, and BMO MRW's changes were present on the OCT with normal visual fields. And patients who were not giving consent, any congenital disc anomaly, closed angles, and history of any intervention to control IOP in past with visual field abnormal, and any systemic illness severe enough to hamper examination and follow-up were excluded from the study. So this is the method through which we got the sample size. According to this stepped pilot study sample size rule, we got 20 in each the group of the study, and taking into account of 10% attrition, 22 were taken in the both group. So the study is conducted only after prior approval from the ethics committee of the AIIMS Patna with CTRI registration. Informed consent was obtained from patients in their vernacular language. On the behalf of participants, participation information sheet was also provided to the patient, and the identity and details about the participants remain confidential with the Department of Ophthalmology, AIIMS Patna. Patient consenting to participation were thoroughly evaluated for ocular and systemic examination. Patient particular visual acuity, slit lamp examination, GAT, OCT examination, and visual field analysis were recorded on the baseline enrolling day. Randomization was done with computer software. Patient investigator were blinded, and the patients randomized to intervention group were advised group 1 drug, that is the topical anti-glaucoma eye drop, and the patient randomized to the placebo group were advised group 0 drug, that is the artificial teardrops, with aim of 25% reduction from the baseline IOP. The investigation which were done were visual acuity by Snellen chart, slit lamp examination for ocular examination and disc assessment, and IOP measurement by GAT and OCT RNFL with BMO MRW with Heidelberg SD OCT, and Humphrey visual field analysis program 24-2 were used. First follow-up was done at 2 weeks to check the 25% reduction in the IOP. Second follow-up were done at 3 months, and the third follow-up were done at the 6 month. Visual acuity, GAT, and disc examination and OCT were repeated on each follow-ups. Data were processed with SPSS, and numerical data is expressed as mean SD. Differences between two groups with student t-test was used, and difference between means were calculated with the help of repeated measure ANOMA test at 3 follow-ups. The p-value of minus 0.05 is considered significant. Coming to the result, total 44 patients were incorporated into the study, with 22 in the intervention group and 22 in the placebo group. And the table is showing the comparison of the mean global BMO thickness between the groups at follow-ups, and we can see over here that the placebo and the intervention group were showing the p-value of more than 0.05, that there is no significant difference between the placebo and intervention group on different follow-ups. This is the Garvey Heath sector, 6 sector on the Heidelberg OCT, showing the mean BMO thickness at baseline in the right eye and the left eye. And these were at in the different group, like in intervention and the placebo group of the right eye and the left eye. This is at the 6th month follow-up, and the primary outcome in the right eye and in the left eye. Here we can see the blue line is showing the placebo group, and the green line is the intervention group, in which we can see that the green line is increasing after second follow-up at the 3 month. Showing that it is improving beyond 3 months of application of the drug in the intervention group. So coming to the discussion, in our study, the final mean global BMO thickness was similar between the placebo and intervention group after IOP control. However, there was a trend of improvement among intervention group after 3 month follow-up, as shown in the repeated measure ANOVA follow plot. Naziazer et al. Have reported BMO MRW is better indicator of glaucomatous damage in moderately myopic eyes as compared to the OCT RNFL. And Lynch et al. Have reported longitudinal RNFL OCT measurement are more likely to detect structural changes than BMO MRW in moderate to advanced glaucoma damage. So conclusion is that there is no statistical significant difference of Brooks membrane opening thickness between the intervention and the placebo group after IOP control by 25% from baseline among glaucoma suspect patient. So further studies are needed to compare the diagnostic accuracy of BMO parameter in glaucoma patients. These are my references. Thank you.
Thank you so much, Dr. Ravi. Very thankful to you that you finished on time. Excellent presentation. I really appreciate that this study has been done very systematically. Dr. Bhavesh, you are part of this study. Would you like to comment anything, or would you like to do you foresee BMO thickness as a objective measurement of glaucoma improvement with the help of drugs?
By this study, hello. Yes, by this study we can say in cases of normal tension glaucoma, there is no role of IP, especially you suspect this is the case of normal tension glaucoma or suspect. So by this we can say there is no role of to reduce the pressure before any started any damage, or you find any defect in OCT or RNFL. So better to observe, and if there is a start damage, then you can prescribe the anti-glaucoma drug. So there is no role to reduce the, there is no changes of RNF, BMO, MRW changes after even reduction of 25% of intraocular pressure. So you can say just wait and watch. If there is a develop any defect, then you can start.
Thank you so much. I'm sure you're going to publish this very soon. I now invite Dr. Priyanka Bharti to come on this stage and present your talk.
A very good afternoon to everyone. Myself, Dr. Priyanka Bharti, first year academic JR in ANMMCS Gaya. My topic is challenges faced in management of glaucoma associated with pregnancy and in lactating mothers. I have no conflict of interest and financial disclosure. Glaucoma and pregnancy is a very uncommon combination, but it constitutes a very challenging situation for treating doctors. The challenge is not only controlling the intraocular pressure, but also having to deal with the mother's mental anxiety and the safety of the child. Now, this picture depicts the water challenges that we encounter. The main challenge is to maintain a critical balance between the drug efficacy and the safety of the fetus. Current advances in the reproductive technology that enables the woman to conceive in an older age has increased the chances of ophthalmologists facing challenging situation for glaucoma in pregnancy and in lactating phase. By this image, we can see that when should we start the treatment? The treatment plan should be advised when the risk of glaucoma progression is the more than the risk and potential side effect of the drugs. The treatment plans depends on the stage of pregnancy, severity of the disease, and the thorough knowledge of the safety profile of the various medical, laser, and the surgical option. It is a sort of tug of war between the glaucoma progression, the vision loss in the mother, and the fetal toxicity. No any anti-glaucoma drugs are considered absolutely safe. Therefore, every drug should be chosen according to the safety of the FDA guidelines. Now let's see the effect of pregnancy on intraocular pressure. Mostly intraocular pressure decreases during pregnancy by the following mechanism. The first is by decreasing aqueous humor production, and the factors are hormone progesterone, which act like anti-glucocorticoids, the estrogen hormone, which act like a vasodilator, and the third is hormone relaxing. And the other mechanism is by facilitating the outflow of aqueous humor. And the factors are decreasing peripheral vascular resistance during pregnancy, hormone beta-HCG, progesterone, and relaxin hormone as well. In 90% of the pregnant female, mostly IOP decreases, but up to only 10% of the cases, it may raise up. And it is most marked in the third trimester. It is very unpredictable, and IOP is the only modifiable risk factor for it. Now see the FDA classification for the medications in relation to teratogenic risk. The category A, there is no risk. Category B, no evidence of risk in humans. Category C, risk cannot be ruled out. Category D, a positive evidence of the risk. And last, the category X, which is contraindicated in the pregnancy. Now by the table, we see the various adverse effects of the different anti-glaucoma drugs regarding the fetus and the infants. The first is alpha-2 agonist, that is brimonidine, which lie in category 2 according to the FDA classification of guidelines, and it can cause uterine hypertony, but there is no any documented case as a side effect. The other drugs like beta blockers, prostaglandin analogs, parasympathetic mimetics, sympathetic and systemic and topical carbonic anhydrase, they all lie in category C with their own side effects. For example, beta blockers can cause cardiac and respiratory arrest and depression. Topical carbonic anhydrase can cause low birth weight and metabolic acidosis. Prostaglandin analogs can cause uterine contraction. Parasympathetic mimetics drugs can cause teratogenicity. Now see the stage-wise management plan of the glaucoma. Glaucoma in pregnancy, in undiagnosed cases, the management depends on the stage of the gestation and the severity of the disease. In diagnosed cases, we should aware about the preconceptional counseling of the mother regarding the benefits and the risk of anti-glaucoma medications to the fetus. The importance of the punctal occlusion because it can limit the systemic absorption of the drug, which is very essential for the doctors and patients as well. The establishment of baseline intraocular pressure, the visual field examination, and the need for frequent follow-up. In the first and the second trimester, brimonidine is the drug of choice, and other drugs like beta blockers, topical carbonic anhydrase, and the prostaglandins may or may not be used. But in the first trimester, systemic carbonic anhydrase should be avoided. In the third trimester, beta blockers and the topical carbonic anhydrase are generally used, and brimonidine and the prostaglandin analogs should be avoided in the third trimester. And in the lactation, beta blockers and topical as well as systemic carbonic anhydrase are used. And my take-home message is, the goal of treatment during pregnancy should be to find a temporalizing measures to minimize the glaucoma progression, and the benefit must be weighed against the potential risk to the fetus. Sometimes even having intraocular pressure more than the desired value, women like to and rather risk their own health for the well-being of their unborn child, and they choose to defer the treatment. So prior to continue the treatment or initiate the treatment, the doctor must be familiar about the different methods and the ways to manage the intraocular pressure during pregnancy and in lactation phase. And at the last, there should be a multidisciplinary approach of ophthalmologist, neonatologist, and with well-informed patients for the adequate treatment of the pregnancy patients. Thank you very much.
Thank you, Dr. Priyanka. That was a very informative presentation.
Thank you, sir.
Will any of the panelists like to comment anything? Amitabh, sir? Do we actually fear about all glaucoma side effects in pregnancy and lactation practically? The impact of the impact of these drugs in fetus.
We do have to look at the impact of these drugs on fetus, but it is very difficult because all have some of the other complications. We need to use some.
Yes, sir.
So if we have to say which is the safest medicine during pregnancy, what would be the drug of choice? Dr. Bhavesh?
I would like to suggest one thing. If, as you say, there are only 10% cases there is a increase in intraocular pressure in pregnancy. Before go to treatment, you should do the CCT. It has been observed that there is a CCT had markedly changes the corneal thickness in pregnancy. That's why you have observed the high IOP. So before treating, should go for CCT, then to start the treatment. And as you very nicely presented, the carbonic anhydrase inhibitor should be avoided in the last trimester, I think. And brimonidine should be avoided in the first trimester. Otherwise, better to go if in third trimester or in second trimester, we generally advise the surgery, like trabeculectomy surgery, and should avoid, or you can go for laser therapy. I would like to prefer laser therapy other than medication to avoid any medicine-related complication of the fetus. So should go for laser therapy or any alternative medicine then other than anti-glaucoma drug.
Thank you, Dr.
Thank you,
Priyanka.
sir.
The surgery or laser therapy.
Dr. Abhishek,
Facility
is he here? May I now invite Dr. Tarannum ma'am for presenting her talk on recent advances in myopia management, very relevant topic. We all come across this every day in our practice. Please.
Good afternoon, everybody. I am going to discuss recent advances in myopia management. It is estimated that 50% of the world will be nearsighted by 2050, and we are actually heading towards a myopia epidemic. The cases are continuously increasing over a period of years, and even after this many interventions which we have started currently, the graph refuses to fall down. The risk factors for myopia are genetic, screen time, and lesser outdoor activity. The causes of progression is same, including diet like fast food. Children start watching TV at a very early age. The screen media exposure begins at 6 months. In 2014, US study, on an average, children under 2 years actually spend 3 hours per day viewing the screen. This is very concerning, as screen media may impact childhood development. Also, screen time exposure was significantly associated with myopia in children and adolescents in multiple studies. Notably, screen time exposure from computers is more as compared to TV, has got a more significant impact. So how do we control the progression? Outdoor activities. This is the single most important factor. And how many hours is important? At least more than 2 hours. So multiple studies have shown that outdoor activities have improved the controlled and also prevented myopia from occurring. Outdoor activities was defined as the time spent in outdoor activities in daylight, such as playing on the ground during break periods in the school, playing outdoor sports, riding a bicycle, swimming, running, playing in park, and so on. All the studies have demonstrated significantly inverse relationship between outdoor activity and myopia. The other thing important is light. Exposure to brighter light, outdoor light could enhance dopamine release, which could actually inhibit axial length elongation. The comet trial which was done, and it was found out that myopia progression was actually more in winters as compared to summers. The importance of light is so much that exposure in the perinatal period is also very important. Children who are born in winters were more prone to development of myopia and progression as compared to children who were born in summers. So how do we track how much light exposure our children are getting? So these watches were made by a Chinese company, and they have got the GPS tracker and also sunlight tracker. Recently, the Apple phone also introduced in their app as time in daylight app, so that they can trace the number of times spent in light. My Light is another device which has been made by the LVPI Hyderabad, and it has been found to be effective in tracking myopia, sunlight for myopia patients. The other important thing that is important is vitamin D. So it has got a weaker correlation, but still the correlation is there. So when you are treating this myopia patients and you feel that his outdoor activities are not good, then you can actually give him vitamin D in the dose of 400 to 600 international unit, as recommended by the Indian Association of Pediatrics. The other thing is that when your children has to go for the online classes and he has to use the computer, at least restrict it to less than 2 hours per day, and follow the 20-20 rule. 20 minutes, for every 20 minutes you have to look at a distant object 20 feet away for at least 20 seconds. And this is also very important. And what about the myopia drops? So there is so much misconceptions about these drops, which I want to clear over here. The drops, atropine 0.101%, was unanimously accepted after ATOM 2 study came out for myopia. So what are the WHO recommendations? It recommends between the age of 6 to 10 years with myopia at least more than 1 diopter, and there is a documented progression of myopia of more than 0.5 diopter per year. So you can't give myopia, if you see a myopia case, and you can't give the drops in the first visit only. So if you have to track these children, and if you get a good response and the myopia has stopped progressing, then you can actually stop atropine, but you have to taper and stop. If the moderate is response, then myopia progression is still there, but it is slower, then you can continue the drug for another 1 to 2 years. And if the response is poor, then you can actually stop the drug, but that also has to be done in tapering dose. Now coming to the DAMES glasses, the defocus glasses, these are a recent introduction into myopia, and they are very good. So they have been proven to reduce myopia by 60% by 60% over 3 years if they are worn, and they cause myopia decrease in axial length progression by causing a peripheral defocus. They don't obstruct with any of the activities of the children. There are multiple lenticules, and if you see them with microscope, then only you will be able to see these small lenses. They look like normal glasses, and they are there for they can be given. How does ortho-K works? It works by flattening the cornea. Health education and government regulation is very important because myopia is a public health problem. In 2018, CBSE board guidelines for school was to have 45 minutes of games period daily for physical activity in the school. But most of the schools are having games period only once a week. Government bodies should ensure and should make every effort that daily physical activities are restored in all the schools. In a nutshell, after COVID-19, we have seen a global increase in myopia, and the current evidence-based treatment for humans are more outdoor activities, frequent pauses from near work, longer distance in near work, atropine eye drops, defocus, and ortho-K. With this, I come to an end. Thank you.
Thank you, ma'am. Just a couple of questions which I always wonder about. So what are the indications for starting atropine drops for the larger interest of
the indication is like if there is a documented myopia is more than 1 diopter, and the child is between 6 to 10 or 14 years, And if there is documented progression of myopia over a period of 1 year, 0.5 diopters. That is the indication. Less than 6 years, it shouldn't be given.
And what if a patient comes to you for the first time with -4 or -5 myopia? Should we start or not?
Yeah, if it is the first, like if a patient comes to me and he has got his previous prescription done elsewhere, and if it was like -3 elsewhere and now it has come at -4, then you can start.
Suppose he has not seen anyone and he comes to you for the first time.
Then
but
I'll
कभी
wait.
दिखता नहीं है.
Then I'll wait.
Then we should wait.
Yeah, yeah.
Tell our patients that do not see on the screen, at their parents, most of the studies are on screen now. So how do you counsel these patients to spend outdoors or to spend less time on screen?
Yeah, that is why, because that is why I included that slide on the CBSE and regulation. So because most of the time your child is at school, and school is not ensuring a single games period over a day. They are giving a games period in a week, and you can't just go out. So at least if they give 45 minutes to the child in the school, and if you take around 45 minutes in the evening, you can take him around and do some cycling and all, so it will cover 2 hours. So that will be great for the child. So because the schools are not following the regulation, that is why we are having this problem. I feel like that.
Thank you, thank you.
There are already open spaces around. हम लोग छोटे थे तो कहीं भी खेल लिए.
Yeah, that is why school becomes important. Yeah, yeah. So that is the thing why I wanted to emphasis on the school. School comes CBSE schools and good ICC schools and every good schools. They have this कि इतना बड़ा playground होना चाहिए. उसके बिना school नहीं pass होता है. And they have the playground. They don't let the children play. That is the problem.
Ma'am, in most of the high myopic patient, they will be, if they present late, they will have some amount of myopia. So how useful is orthoptic in that one?
Yeah, orthoptic works very wonderfully in myopia. But the only thing is that in myopia there is chances of progression if we are doing orthoptic. Even the orthoptic founder like Santan Gopal admits to that. And we always try to do patching in myopia first, then we shift to orthoptic if it doesn't improve.
Thank you.
Thank you so much, Tarunam ma'am. Yeah, please. We are.
If he is already on low dose of atropine and like what his myopia is, and eye refractive status, -2. -2 I can I will see on regular follow-up. I won't stop the atropine. If he's already an atropine, I won't stop. I'll see him like every 6 months, and if he remains -2, I'll taper and stop.
One announcement.
Thank you
Requested to everyone, please collect your certificates from registration counter.
Now I invite Dr. Santosh to speak on posterior fixated iris claw oil. Please, Dr. Santosh.
Thank you, sir. A very good afternoon to one and all. And at the outset, I would like to thank Bihar Ophthalmic Society for giving me this opportunity. And I will be presenting few cases on retropupillary iris claw. As this first case is actually post VR surgery case, so you can see some laser patches here. So this is subluxated IOL here. First you can see the technique. You have to make this side port. Followed by sclerocorneal incision, measuring about around 6 mm, sorry. So the pupil size should be ideally actually mid dilated, because if it is too dilated, then you may not get the chunk of iris tissue to enclavate in the fissure of the the iris claw haptic. I'm just taking the support of iris repositor just to maintain the shape of the pupil. So it will be very ideal to introduce it anterior-posterior, and then when you go there, you just turn it, and it is a blind technique because you are not seeing the fissure. So you have to just see the indent, and then you just enclavate the iris tissue in the fissure. In case the pupil is not very ideally dilated, then you can just pull it little bit, and you can see the the haptic. So this was my first case, and in most of the cases we will be suturing because most of these are post-VR surgeries, so there are chances of hypotony. My second case is a dislocated multi-piece IOL actually. So we should always do good amount of vitrectomy or at least anterior vitrectomy just to pull out the IOL safely. And we could have put it as SF IOL, but somehow the haptic was little bit damaged, so I opted for putting iris claw IOL in this case also. Same technique. If there is amount of posterior capsular remnant left there, then either you have to cut it or you have to insert the haptic between the remnant and the iris tissue, which was the purpose to show this case. Third case is a phakia case. After doing a vitrectomy, the pupil was not round because of some fibrin attached there, so I have to just clear it first. Usually diffuse iris atrophy is a contraindication, but if sectoral iris atrophy is there, then you can just avoid that area, and that is in the fourth case you can see some amount of iris atrophy there, but you just have to avoid that particular area, and iris claw can be easily fixated in those cases also. In cases of posteriorly fixated iris claw IOLs, actually we are not doing iridotomy regularly, as contrary to the anteriorly fixated iris claw IOLs. So here IOL drop was there, we just picked it out, and then the same procedure. Usually we use long IOL holding forceps to make the procedure safer, and after enclavating the first one, you have to just exchange your hand and then go very smoothly with this for the enclavation of the second one. This is a technique with a very short learning curve and can be done with a small amount of practice only. So these were my cases, and thank you all for your very patient listening.
Excellent demonstration of the videos. Do we have any questions?
I have a question. Very nice video, but I want to know how you ensure the centration of the lens, because it is a blind procedure.
Yeah.
And my expert, I am not very satisfied about the centration of post-op centration of the optic.
So in most of the cases, actually the pupil size should be mid-dilated, and then if you are like not seeing the haptic, if it is not mid-dilated, or if it is the pupil is a little bit smaller size, then you just pull it out just little bit, see the optic haptic junction, and then you will have to feel it somehow by the IOL that one Sinski hook. Just you feel the indentation and just go in between. That is the way, because it's a little blind technique, and then you always have to try the mid part of the iris stroma to be tucked in. That is the thing.
it really possible to do it with an AC maintainer and the anterior vitrectomy that comes with the phaco machine? Is it important to, on all the cases you went through pars plana and you're putting in an iris claw? So I was just wondering if there is any other way possible.
Yes, of course, ma'am. Actually, you need AC maintainer just to avoid the hypotony, because most of these cases will be post-operative.
It can be done with the AC maintainer without going through the pars plana.
Yes, ma'am. Because you just have to do little bit of anterior vitrectomy. If IOL is in the the anterior parts, but if it is hanging in posterior parts, then you should go for little bit more meticulous vitrectomy. Otherwise, many of the anterior segment surgeons are doing it in their camp practices.
And how many cases of disinclination in your series?
I have seen 2-3, and in those cases actually you can either re-enclavate, but if the iris tissue is not in a good shape, then you have the cutting of the other haptic is really very difficult, because it may bleed, and those cases we have seen. And also one more thing is, like few cases we have faced with retinal detachment under the iris claw. So I think there is one misconception that it should not be dilated. Actually, in post-operative cases for let us say for 4 weeks or 6 weeks, we should avoid dilating, but later we can easily dilate and do the other procedures.
Is it spontaneous disinclination? Does it have anything to do with the timing post-surgery? Does it happen early, or it is delayed, or it has no reason at all? Any particular?
Disinclination, ma'am, mostly it happens with the iris atrophy I have seen, because if we follow those cases for 7-8 years, some amount of iris atrophy, or because of uveitis, I think there may be some loosening there. Thank you, sir.
Yeah, but it doesn't dilate well actually post-op. I wanted to see the periphery of the retina, I couldn't dilate it well.
Yes, sir. It doesn't dilate very well, but you can see, I think after dilating, you
what
can see
happened, one of the doctor, his father actually, and the left eye was gone, right eye was this anterior inclination of this iris lens, and then I could not see the periphery. Patient actually later developed RD, and even now that eye is also gone. So one actually, contradiction is, if you want to see well the periphery of the retina, better not to do these lenses.
Sir, the dilatation is more difficult in anteriorly fixated IOLs.
Even in posterior I've seen, I couldn't dilate, mid dilated only. So if I want to see the periphery,
yes,
it's very difficult to see.
A little difficult, sir.
Yeah.
But even I have shifted now to scleral fixated IOLs, but these are, I think, relatively with easier learning curve. So usually we used to do many cases of iris claw.
Yeah, so
just I showed my old cases actually.
High myopic eyes and all, it's better to avoid these lenses, because then you can't see periphery much.
Yeah, yes, I agree.
The other thing is the centration of the lens, Bhavesh sir. You can use post-op pilo. We did it. So it will affect.
We are running short of time by almost an hour. Thank you so much, Dr. Shantos. I would like to invite Dr. Gyan Bhaskar, our Chairman Scientific Committee, for giving a talk on role of Nepafenac in pain and inflammation management. Dr. Gyan.
Thank you, Dr. Ashish. Good afternoon, everyone. Basically, I am here on behalf of JB Chemical and Pharmaceuticals. This is a sponsor talk, the role of Nepafenac in pain management and inflammation management. Basically, all of you know, there are two basic post-operative management anti-inflammatory. One is the steroid and other is the non-steroidal anti-inflammatory. And always the combination steroid and non-steroidal as the best way to manage the post-operative pain and inflammation. So here is the non-steroidal anti-inflammatory drug versus the corticosteroid for controlling inflammation after the uncomplicated cataract surgery. There is the non-steroid alone versus the corticosteroid alone. With the non-steroidal plus corticosteroid versus the corticosteroid alone. We see that in this study, the combination of non-steroidal anti-inflammatory with the steroid is the safer way to treat the post-operative cases of any case of the cataract adult SICS or phacoemulsification. When we talk about the nefafenac 0.3% potency and convenience, basically nefafenac comes in the suspension of 3.3%. And it is a powerful post-operative pain and inflammatory control, and 0.3% nefafenac preparation, and it is the unique formulation, and it is also increased retention time, and it is enhance the viability, and because it is uniquely prepared, so it can be used with once daily because it has an increased retention time. When talking about the dose and indication, it should be indicated once daily for the controlling of the post-operative pain and inflammation, and this is the nefafenac 0.3% suspension. Once daily because of it has a unique preparation of the higher concentration of the guar gum, and with the high viscosity and a small, there is a small particle size, so it retain it is retained in the cul-de-sac more. Post-operative pain and inflammation control, these are the multicentric randomized double mask active control phase 3 study. It shows that if we compare with the nefafenac 0.1% versus the nefafenac 0.3%, 3 times versus once daily, it is the safer and convenient and equally effective. The post-operative pain and inflammatory control, and the primary endpoint of this study is the nefafenac 3% is effective and it total clearing the inflammation, and also nefafenac 0.3% is effective and resolve the pain in every cases. And regarding the, we talking about the regarding, it is the once daily and it is well tolerated by all the patients. Although they have some complication, but it is not even that it respond. It adversely not so more that patient does not any more side effects. The comparison of the nefafenac plus steroid versus the steroid alone in the ocular control of the ocular inflammation of the phacoemulsification. These studies show that the studies that the addition of the nefafenac to any steroid, here is mentioned the prednisolone, is significantly reduce the intraocular inflammation after the phacoemulsification. It is managed the post-operatively. So summarize that nefafenac 0.3% one daily is well as effective dose of the 3 times 0.1% nefafenac. Thank you so much, sir.
Thank you, sir. Do we have any questions for Dr. Gyan? Anyone in the audience? We still have some time.
बिल्कुल क्वेश्चन पूछ सकते हैं.
Yeah, yes, Dr. Ajit.
Actually, patient complains with a 0.3. It's very difficult to get that very thick. It's very thick than the other suspension forms. So, but it's a single dosing, and does there any surface related complications? Does it increases or not?
Basically, most of the company is coming with the single dose 0.3% nefafenac. Basically, when still the any medicine with the gum, it transient, there is a blurring of vision also, patient is having transient blurring, but it is a convenient because it is the once daily, and the patient is already having the post-operative some complications, so most of the patient is not so much worried about.
And being an oculoplastic surgeon, you get many patients of the related to these preservative induced punctal things.
Basically these medicine are not we are not using so long, इसलिए उतना complication बहुत नहीं होता है. At least we are using 3 to 4 weeks maximally. Main purpose of the non-steroidal post-operative installation is because to prevent the post-operative CME. Generally, we know by the literature it is CME develop post-operative there is 4 to 6 weeks. So it is not using longer period, so there is less chance of punctal occlusion or any complication.
Okay, but CMEs are common in my experience, especially in a glaucoma. If you are doing some surgeries over glaucoma medication, glaucoma patients, as a combined surgery, we get CMEs. I have got 3 CMEs which are around 675 or 475 CMT in just 1 month post surgery.
So the longer the duration of the surgery, the chances of risk of
surgery.
CME increases for you, because
Also, if we are doing the surgery along with the trap, maybe chance of sudden hypotonic, maybe the other cause of the prolonged surgical
Glaucoma itself, pre-existing glaucoma on anti-glaucoma medication itself increases the chances of post-op CME in cataract surgery.
Okay,
thank you.
sir.
Thank you, JB Chemicals, for coming with this newer concept and molecules and helping us in the practice day to day. Just to let you know, JB Chemicals is a very well-known company who has some of the very well-known drugs in the market like Silasar, Metrogyl, Rantac. You name it, they have it. I now invite Dr. Deepak Agrawal, sir, a prolific VR and anterior segments surgeon on. You'll be talking on reimagining drying and durability with brolucizumab. I welcome Dr. Deepak, sir.
Thank you, Dr. Ashish. Good afternoon, everyone. Mine is also a sponsored talk from Novartis. So we all know that fluid plays a very significant role in the pathogenesis and in the pathogenesis of wet AMD and diabetic macular edema, and all our treatment decisions are based on the presence of fluid on the OCT. And by now we know that all fluid is actually bad for the retina, whether it is intraretinal fluid, subretinal fluid, or the sub-RP fluid. However, having said that, some amount of subretinal fluid may be tolerated to some extent. But besides that, there are so many unmet needs when it comes to patients with AMD and DME, because the number of injections which are needed is quite much, and therefore the adherence of the patient to the treatment, and it has been found in the real world that 70% of the patients are undertreated and there's a high injection burden, and 80% of the eyes received only 3 or less intravitreal injections for 1 year, and therefore a need for an agent which is potent and which can provide a sustained action was needed. And here brolucizumab scores over most of the other anti-VEGF agents because it's a very small molecule. It's a 26 kilodalton single chain antibody fragment, and therefore a large number of molecules can be packed in a certain volume, and this increases the duration of action of the drug. And because of its small size, it can penetrate much below the RP, and therefore its efficacy is much more. And that is what is seen in our trials and clinical practice also. So when we come to DME, the Kestrel and the Kite trials have shown that the vision gains achieved with 6 milligram of brolucizumab was comparable to aflibercept with better drying. So you can see here that although the visual letter gain was almost equal with aflibercept and brolucizumab, the drying effect was much more with brolucizumab, and that is what is needed because we want the retina to be fluid free. So again, you can see these graphs here which shows in comparison to aflibercept that there was a robust improvement in the central subfoveal thickness with 6 milligram of brolucizumab. The number of injections needed was lesser with brolucizumab at week 100, 7 injections with brolucizumab and 9 injections with aflibercept. So having said that, again the drying effect was much better with brolucizumab. The IRF and SRF was much lower, and the post-hoc analysis also showed that the time to achieve the dryness was much earlier with brolucizumab than aflibercept. And the time to achieve a central subfoveal thickness of less than 280 was again less with brolucizumab compared to aflibercept. So for diabetic macular edema, a greater percentage of brolucizumab treated patients achieved dryness. The time to first have absence of IRF and SRF was shorter in brolucizumab. So in AMD, again, we know the Hawk and the Harrier trial. Again, this showed comparable results with aflibercept, and you can see here that the drying effect was much more with brolucizumab, and the visual gain also here was comparable. Most importantly, also the fluid fluctuations was much less with brolucizumab. That is, the fluctuations was much more with aflibercept, and therefore the visual gain, final visual gain, was supposedly much more with brolucizumab than aflibercept. There was a reduction in the sub-RP fluid thickness with brolucizumab compared to aflibercept, and greater percentage of reduction in the PD thickness also, as can be seen in the graph here. So this is the brolucizumab, and this is the aflibercept. So having said this, there was sustained vision gain with smaller number of injections seen with brolucizumab. The treatment-free interval could be extended to more than 12 weeks, that is 3 months with brolucizumab. And there was higher CSFT reduction. The brolucizumab had shown faster and more drying effects. So I'll come to some clinical cases. So this 65-year-old gentleman presented to us with sudden metamorphopsia. The vision in the right eye was 3/60. The left eye was 6/9. You can see here that this is such a tall PED here, multiple PEDs here, sub-RP fluid, SRF, and some SHREM. And just with one injection of brolucizumab, you can see the flattening of the PED over here. And after 2 months again, we had injected the second dose, and you can see here that the PED had almost completely flattened, and the visual acuity gain was 6/36 in the right eye. This is another case of IJT with SR-NVM, and you can see here that the vision in the right eye was 5/60, and after the second injection, you can see the flattening of the you can see the regression of the SR-NVM, and the anatomical change was much better. The resolution was so good. So these are the consecutive pictures. Another case of an IPCV here, you can see here the PED here, and after injection it had regressed over here to this level. Even in DME, we can see that this patient here was on ranibizumab, and after 3 injections of ranibizumab, there was recurrence, and we had given Paginex to the patient after the 3rd injection, and you can see here, after giving Paginex, there was resolution of the diabetic macular edema, and this was sustained for 4 months, but after 4 months, again, the patient needed another dose of brolucizumab. So the duration of action of brolucizumab is quite sustained, and this is another patient of DME here. You can see SRF, intraretinal fluid in both the eyes, and after 1 injection of brolucizumab, there was so much of drying effect, and it was sustained for more than 3 months, and patient required injections only after the 4th month. So having said this, the drying effect of brolucizumab clinically also is quite high, and the much spoken about the intraocular inflammation, which is seen more in the Western world. In India, however, the risk of intraocular inflammation was not that much as it was reported. One of the reasons probably was that in our patients, we are not giving loading doses. Most of us are not giving loading dose of every month. We are giving it every 3 months or every 2 months. So therefore, the risk of vasculitis was not that much in India. Only 1 case of RP, RIP I could see. And another thing which we found was that results are better if the patient was treatment naive. That means if the patients were not treated with any other anti-VEGFs before, the results were much better, and the risk of intraocular inflammation is also less. Thank you.
Sir, for elaborating so nicely on brolucizumab. Dr. Santosh, do you have any questions for Deepak sir?
Sir, the drying effect of brolucizumab is absolutely superior to most of the other injections. Would you like to suggest this one brolucizumab for treatment naive patients or for all the resistant cases only?
Yeah, that is one thing. The trials have shown that it can be used in resistant cases, but the studies which have been published in India, mostly from West Bengal, we have seen that even when we have used it in treatment naive patients, they are doing very, very well. And second point which came out from those studies was that the chances of intraocular inflammations also was much lesser in these patients who were treatment naive patients, especially for IPCV. Especially for IPCV patients now, the drug of choice, we consider it to be brolucizumab, because the drying effect, the penetration is so much that with one single injection, we have seen so much of reduction in the PEDs. And the risk of RP RIP, which was considered that if the PED is going to be very tall, the risk of RP RIP will be high. That was not the case with this.
Thank you, sir.
Thank you.
Thank you so much for your patient listening. With this, we come to the end of the session. I now hand it over to Dr. Bhavesh Sir for the next session.